I want to discuss a new approach for the prediction and prevention of preeclampsia. And I want to remind you all that preeclampsia is a leading cause of maternal and perinatal mortality and morbidity, and that worldwide more than 50,000 women are estimated to die every year as a result of preeclampsia-related complications. So it is an important condition to identify and prevent the associated complications. I also want to discuss the concept that although preeclampsia may have different implications if it happens early compared to later in pregnancy, a recent concept that we may be dealing with different types of diseases is unlikely. And what is much more likely is that we are dealing with the same condition, but it has a spectrum of severity that is related to the gestational age at presentation. We know that the associated histological changes in the placenta are inversely related to the gestational age at presentation. We know that the risk of fetal growth restriction in association with preeclampsia is inversely related, almost in a linear fashion, with the gestational age at presentation. We know that the risk of perinatal death and maternal death are also inversely related to the gestational age at delivery. Although preeclampsia presenting before 37 weeks or even before 34 weeks are therefore quite uncommon, because the majority of cases of preeclampsia occur after 37 weeks, the contribution to maternal and perinatal mortality and morbidity is higher from the preterm rather than the term preeclampsias. The approach that I propose in terms of the prediction, prevention, and better management of affected cases comes with the concept that the time has come for us to invert the traditional approach to prenatal care. An approach which is in origin more than 80 years old now, whereby women are seen every 4 weeks until 28, and then every 2 weeks until 36 weeks, and then weekly until delivery. A philosophy of the past which was acknowledging a defeat in our ability to predict and prevent conditions, and it was concentrating in a series of clinical visits, increasing in frequency with advancing gestation, so that when the disease occurs, we can detect it. The new approach is essentially based on 3 integrated clinics. One at 12 weeks, 11 to 13 weeks, where the aim is to identify the high-risk groups for preeclampsia, fetal growth restriction, and stillbirth, and through pharmacological intervention to improve placentation and reduce the prevalence of the disease. Another approach at 22 weeks, where some of the women that we originally identified as being at high risk of impaired placentation can now be moved into the low risk category because there was no abnormal placentation, but a mere delay in normal placentation. And then a 3rd trimester approach, perhaps at 32 weeks, where women that have developed preeclampsia or are now soon to be developing preeclampsia can be identified, so that through closer surveillance we can prevent stillbirth and define the best time for delivery and the best place for such delivery, with the objective now of reducing the consequences, both for the mother and the baby, from the development of the disease. So a three-stage strategy. And in each one of these visits, the concept is that we combine information we get from the mother, from the history, from the maternal characteristics, together with a series of biophysical and a series of biochemical tests, and then we get a combined risk, which is being modified with each visit. Many professional bodies acknowledge the importance of early identification of women at high risk for preeclampsia. For example, the National Institute of Clinical Excellence, the NICE guidelines in England, recommend that when we first see a woman in her first hospital visit, we must obtain a series of criteria, and if these criteria are fulfilled, then the patient is classified as being screen positive, and then these women should be treated with low-dose aspirin. However, with this approach, each one of the criteria are expected to perform independently from each other, and about 10 to 12% of women are classified as being screen positive. When we examined 120,000 prospectively assessed women having routine antenatal care in a series of hospitals around London, we found that the performance of this method of screening is quite poor. It can identify about 40% of the women that are destined to develop preterm preeclampsia and about 30% of all women that would develop preeclampsia. A new approach using the Bayesian theorem that treats all of the factors by taking into account their interrelationship and assuming that preeclampsia is a single disease with a wide spectrum in severity, primarily dependent on the gestation at presentation and the gestation for which delivery is needed, has now been developed. This approach uses a survival type model and considers that if a woman was to stay pregnant indefinitely, on average, she would develop preeclampsia at around 55 weeks of gestation. We then have a Gaussian distribution of delivery with preeclampsia, and each one of the maternal factors that are well known to be associated with increased risk for preeclampsia is modifying the gestational age at delivery of this whole population. If a woman is at very low risk of developing preeclampsia, then the women that will deliver with preeclampsia will be delivering many weeks after 40 weeks, and therefore they will not actually develop preeclampsia before delivery. On the other hand, a series of factors, increasing maternal age, increasing maternal weight, Afro-Caribbean, racial origin, previous history of preeclampsia, family history of preeclampsia, starting the pregnancy with chronic hypertension, diabetes, and antiphospholipid syndrome, systemic lupus erythematosus, these risk factors operate by shifting the gestational age distribution to the left. So many women will actually be developing preeclampsia before they deliver. This concept of a competing risk process where all women would develop preeclampsia if they were allowed to remain pregnant indefinitely, but whereby there is a competition between delivery for preeclampsia or delivery for some other reason allows a concept that preeclampsia, first of all, is a continuum, and secondly, is the basis on which we can now combine the background a priori risk imposed by the maternal characteristics with a series of the results of biophysical and biochemical tests. The first biophysical test is that of the uterine artery pulsatility index, which actually is a measure of what we believe is the underlying pathophysiology of the disease. We believe that preeclampsia is a consequence of impaired trophoblastic invasion of the maternal spiral arteries and their conversion from narrow, high resistance into dilated, low resistance vessels. We do an ultrasound scan at 11 to 13 weeks. We then align the transducer sagittally to visualize the cervix. We use color Doppler and we tilt the transducer from side to side to visualize the uterine arteries. And then we use pulse wave Doppler to assess the waveforms. There are specific criteria that need to be followed to get accurate measurements. The pulse gate must be narrow to cover the whole vessel. The angle of insonation, like with all types of Doppler assessment, should be less than 30 degrees. The peak systolic velocity should be at least 60 centimeters per second. We measure with the software of any ultrasound machine the pulsatility index on the left and then on the right, and we use the average of the two measurements as the mean pulsatility index. We have carried out extensive studies with the measurement of uterine artery PI at 11 to 13 weeks, and you can see on the right the relationship in the black dots, the cases that subsequently developed preeclampsia, and the uterine artery pulsatility index at 11 to 13 weeks. In women that develop early preeclampsia, severe disease requiring early delivery, the pulsatility index is very much increased, but with advancing gestation, for the late preeclampsias, the pulsatility index in early pregnancy is essentially normal. You can see the relationship between the pulsatility index and the gestational delivery, and it is very clear that there is a single distribution, but we are not observing a bimodal distribution that would have suggested that we are dealing with two different types of disease. We have a spectrum disease, the spectrum of which is reflected at the gestational age at delivery, rather than two different types of diseases, early and late preeclampsia. The other biophysical marker of preeclampsia is the mean arterial pressure. Again, it is critical that this is measured following a specific protocol. The patient must be rested for about a minute. We must use the appropriate size cuff and place this on the left and the right arm. We must use a reliable, validated, automated machine, and these are quite cheap, they are less than $50. And we must measure the mean arterial pressure on the left and the mean arterial pressure on the right. And after 1 minute, we take a second measurement, and the four measurements together are used to take the averaged mean arterial pressure. On the right, you can see the distribution of the mean arterial pressure in women that subsequently develop preeclampsia. And again, in women that develop early preeclampsia, the mean arterial pressure at 12 weeks is quite high. In those that develop late preeclampsia, still the mean arterial pressure is increased, but less so than in those with early preeclampsia. The two important biochemical markers, and you have investigated many for their value, but the two important ones are PABA and PLGF. And we have carried out extensive studies with the support of Perk and Elmer, and we have found that in women that will develop preeclampsia, these metabolites at 11 to 13 weeks are reduced, especially in those that will develop severe early onset disease. We then combine the information we get from the history that defines the prior model, the survival type of prior model, and then we add onto this model the measurements of mean arterial pressure, uterine artery pulsatility index, PABA and PLGF, taking into account the interrelationship of these biophysical and biochemical markers. And by this approach, at 11 to 13 weeks, we can detect more than 90% of those that will develop severe early onset preeclampsia requiring delivery before 34 weeks. We will detect about 75 to 80% of those that will develop preterm preeclampsia requiring delivery before 37 weeks, and we will detect a bit more than 50% of the total number of cases of preeclampsia. The same approach can be used for the early prediction of pregnancies that will subsequently develop severe fetal growth restriction in the absence of preeclampsia. We know that if you have small fetuses, the majority of cases are normal small babies because their mothers often are very small themselves. We have a very, very small group of small fetuses that are small because they have an abnormality. They have trisomy 18, they have bilateral renal genesis, they have a major congenital infection like cytomegalovirus. But we have a group where the babies are small, they're normal, but they're small because of starvation. And this starvation is a consequence of impaired placentation. We can identify this group by a combination of various characteristics in the maternal history and the uterine artery pulsatility index together with a measurement of maternal serum PABA and PLGF at 11 to 13 weeks. And we have demonstrated that we can detect more than 50% of the cases that will develop small babies before 37 weeks. First trimester assessment by a combination of maternal characteristics, biophysical and biochemical tests can also identify a high proportion of the women that will subsequently end up with a stillbirth, particularly stillbirths that occur before 37 weeks. A high proportion of such cases are associated with preeclampsia and or fetal growth restriction, and inevitably they have the same biophysical and biochemical pattern as those specific conditions that cause them. Why is it important to identify preeclampsia, fetal growth restriction, and stillbirth in the first trimester of pregnancy? Extensive studies in the last few decades have demonstrated that the use of aspirin has some beneficial effect in pregnancies in terms of reducing the complications associated with impaired placentation. However, this effect is quite small. A specific analysis, however, of the effectiveness of this therapy in relation to the gestational age at which the therapy is initiated has quite clearly demonstrated that the use of aspirin before 16 weeks of gestation is associated with a substantial, a halving reduction in the risk of subsequent development of preterm preeclampsia, fetal growth restriction, and perinatal death. Whereas if aspirin is initiated beyond 16 weeks, the effect is only minor or insignificant. It is because of this evidence that it is critically important in any strategy aiming at preventing preeclampsia and its complications, we should be identifying the high-risk group in the first trimester of pregnancy. Quite often people ask, but how could aspirin improve placentation? And the recurring theme is that we don't really know. However, Fabrizio da Costa from Brazil, originally working in Australia, has carried out some beautiful scientific work that has demonstrated that in pregnancies with preeclampsia, there is increased evidence of apoptosis and reduced placental growth factor production. And he showed that if we take such pregnancies and we treat them with aspirin, we are reducing apoptosis and we are increasing the production of PLGF. In the slide on the top, we are looking at the apoptosis index in the first histogram of normal pregnancies at a much higher value in pregnancies with preeclampsia. On the right, you can see how the rate of apoptosis is dramatically reduced with the administration of aspirin. Similarly, at the bottom, you can see the cases of preeclampsia and those that were treated with aspirin and how the treatment with aspirin substantially increases the production of PLGF by trophoblast. The evidence relating to the effectiveness of aspirin started from the beginning of the second trimester, at around 13 weeks, arises from a meta-analysis of previously published small studies. And therefore, there is a repeated desire that the case is proven by a further major randomized study. And this is exactly what we will be doing in a study, a multi-center European study funded by the European Union, the Osprey trial. Essentially, we will undertake first trimester screening by the combined test, maternal characteristics, PLGF and PABA, uterine artery PI and MAP, identify the 10% of the population at highest risk for development of preterm preeclampsia, and recruit these women into a randomized study on the assumption that about half of the women will agree to be randomized. We will need to study about 1,600 women, and half of them will receive aspirin, 150 milligrams per night, and the other half will receive placebo. And if the effect of aspirin is to reduce the rate of preterm preeclampsia by 50%, this study will prove the value of both screening and prevention with prophylactic use of aspirin. The primary outcome measure in our study is the development of preterm preeclampsia. But we will also be looking at the rate of early preeclampsia and total preeclampsia. We will be looking at perinatal death. We will be looking at birth weight. We will be looking at the neonatal outcome and as well as death admission into the neonatal unit. So this is a study that has long been asked for, and we have started it, and we will have the results by July 2016. In the Osprey study, we will be assessing the whole population at around 12, 20, and 32 weeks. And in the group that would be randomized, we will have a series of telephone calls to ensure compliance with the drug that has been allocated to them, and assessment, full assessment, biophysical and biochemical, at the beginning, the middle, and towards the end of the pregnancy. I now want to direct our attention to the possible value of a second visit at around 22 weeks in pregnancy. The objective of these visits is to redefine the risk of those that we originally classified as high or low risk. The first data that we received from this study relate to the uterine artery pulsatility index and the mean arterial pressure, but we will soon be looking at the results of PAB-A and PLGF that we have also measured in these pregnancies. And the data are already demonstrating that assessment at around 22 weeks improves the prediction of subsequent development of preeclampsia compared to the original assessment at 11 to 13 weeks. And again, with this assessment at mid-pregnancy, we are better at identifying the women that will be developing preterm rather than term preeclampsia. More recently, our attention has focused into the third trimester. I know there is a lot of interest in finding a simple test that will be assessing women turning up in hypertension or specialist high-risk clinics that present with various symptoms like headache or abdominal pain and various measurements like proteinuria or hypertension, in order to distinguish between those that will be developing preeclampsia from those that will not. And in the group that will be developing preeclampsia, to identify those that would require delivery within the subsequent 2 to 3 weeks. I think that such research is useful for specific patients that present with symptoms. However, if we want a strategy to identify the vast majority of affected pregnancies, we need to introduce routine screening in a similar way as we have done at 11 to 13 weeks, and do so at around the 32nd week of pregnancy. The data from such a visit are very clear. At 32 weeks, the women who will subsequently develop preeclampsia have very much increased uterine artery pulsatility index, very much increased mean arterial pressure, and very much decreased placental growth factor. And the magnitude of these deviations from normal are considerably greater than the ones that you had observed at 11 to 13 weeks. So the 11 to 13 week assessment that is primarily aiming to identify a very high risk group that will benefit from intervention, prophylactic treatment in the beginning of the pregnancy is not so good in identifying late onset disease. And that is why we need to come closer to the event by instituting a visit at around 32 weeks. Such a visit can identify, and has identified in our study, all of the cases that will develop severe preeclampsia requiring delivery over the subsequent 4 weeks. I believe that the future will be one where a contingent process of screening will be instituted on the basis of the results of this 32-week assessment, a high proportion of the population that may not require any further assessment, a very small proportion that will require intensive monitoring because they have a very, very high risk of developing severe disease in the subsequent 2, 3, 4 weeks, and an intermediate risk group where the process of assessment would need to be repeated after 4 to 6 weeks. I want to finish by reiterating the concept that we want to promote, a concept that has now been backed by extensive research and extensive data. There is no competition between those that advocate a third trimester test from those that advocate a first as well as second and a third trimester screening. The objectives of the third of the 3 visits are quite different. The objective of the first visit is to identify a very high-risk group that would benefit from therapeutic intervention. The objective of the second visit is to reassess the risk and redefine the high and the low-risk groups. And the third visit is primarily aimed at identifying women that require intensive monitoring for better management of their pregnancies in the third trimester. Thank you.